So, do you guys have any questions for the exam before we get started, or? Yeah, that's the hard part. I can't. Yes, I can see the front of their heads now. It's perfect. Oh, you guys asking me a question, or? I'm sorry. Can you repeat that? The Kahoot should have a decent spread. It won't be exact. I try to usually make it pretty equal amongst the weeks. The bugs and drugs section might be a little bit heavier, just because that's a lot of the newest drugs we hit, and that's pretty important in terms of how that's going to be showing up elsewhere. So there might be a little bit heavier focus on that. What other questions do you have? Wait for a few more to sign in. Okay, well, are you guys ready to get started? Let's do it. Yeah. So try to keep the chatter down just so I can hear if anyone has any questions, but we'll go from there. So maybe two more can sign in, but that's okay. We'll get to it. It should go pretty similar to the last time, but be more focused on the medications that we've covered up now. So first one, let's say we have tendonitis and possible tendon rupture. Which one of these medications do you think would be a concern for that? Again, side effects will be pretty important for the different medications that we covered in terms of common things and unique things as well are good to note for testing purposes. Let me see. The pin should be at the bottom of the screen, bottom left, if you did not get into the game. All right, very good. Yes, so always think about the fluoroquinolones as being a risk for having that tendonitis, and certainly like Achilles tendon rupture is one thing we certainly are concerned with. Can you think of any other meds that would fall into that category? Hmm. Yeah, the ones that end with fluoxetine, that's a pretty good start, but you have like levofloxacin, you have moxifloxacin, those all fit that category. Do you remember who the tendonitis was more likely to occur in? Yep, under 18. Yeah, kids are more likely to end up seeing that. So it's a relative contraindication. We wouldn't always avoid using fluoroquinolones in that group, but certainly we do on occasion. But certainly the thing I would be concerned with. Okay. Okay. Moving on to the next one. Let's see. Got Frodo in the beginning, so we're heading into Mordor now, right? All right. Which of the following conditions would be improved by starting a patient on transdermal testosterone? So now switching gears and going into the endo stuff. Do you think benign prostatic hyperplasia, osteoporosis, gynecomastia, or congestive heart failure? All right. Yeah. So this is an interesting one. So you got to kind of think about sort of the secondary effects from the medications here. So for instance, if you recall when we were talking about how some of the steroids get converted, actually with testosterone, you can see the more testosterone you have in the system, some of that can be converted over into estrogen basically via the enzyme aromatase. So in some cases, some patients may actually have gynecomastia a little bit worsened by that, just because they're producing more estrogen. But certainly, like testosterone has really positive effects on the bones. That's good. How about for BPH? Would that help or worsen if you were giving the patient testosterone? It actually worsens it, yeah, because actually what you end up finding is, and we'll talk more about this when we hit the urology section next semester, but testosterone gets converted over into something called DHT, or dihydrotestosterone. And so when you do that, it's even more potent, and that actually causes further growth of the prostate there. CHF is another one where you might see some like increased fluid retention, hypertension, so that could actually worsen that as well. So osteoporosis would be the correct answer in that case. All right, moving on. So which medication would have a relative contraindication in a patient with hypertension? So it would be oxymetazoline, acetaminophen, diphenhydramine, or pseudoephedrine. So going back to our ENT stuff. Very good. Yeah. So there's actually two right answers on here. I won't do that on the test, obviously, but I will certainly sometimes like to put in some tricky stuff here on the Kahoots. But if you remember oxymetazoline, what route do we normally give that? Anyone know? Yeah, that's typically nasal. So even though that's very local, you can still see some patients, especially those with like uncontrolled hypertension, may have their pressures raised up a little bit. So I'd probably still be maybe less likely to jump to that as like a first line if they had a lot of nasal congestion. But certainly acetaminophen, diphenhydramine, those are totally fine to use. But definitely pseudoephedrine would be the one I would be most concerned with, mainly because it's given systemically. That's where you're going to see the majority of those hypertensive sort of effects, right? All right, very good. Moving on. So, which of the following medications works to inhibit bacterial folate utilization? So, getting into our mechanisms here, would it be moxifloxacin, azithromycin, sulfamethoxazole trimethoprim, or polymyxin B? All right, very good. Yes, so certainly mechanisms are going to be something I might ask on the test. It's a pretty good, like, run of the mill, kind of easy memorization sort of question. We'll get more involved in that, but it's definitely good to know the mechanisms. Yeah, so sulfamethoxazole trimethoprim, kind of working on two steps of the folate utilization pathway there. So that's a good mechanism to remember there. How did like azithromycin work and the other macrolides? You guys remember? So like, did the macrolides work on like on the cell wall? Did it work on say protein synthesis? Huh? There you go. Yep, there you go. So if you had like an answer choice on the test, you might be able to come up with that certainly. How about the fluoroquinolones? Yep, good topoisomerase, right? So they're going to help to cause more strand breaks in the DNA because it won't be able to cause the single strand breaks to occur. So DNA damage occurs, and then that eventually kills off the cell. Very good. All right. So next up, then we have application of corticosteroids to which area would most likely lead to systemic effects? So to the soles of the feet, the axilla, the forearms, or the hands? What do you guys think? All right, very good. So why do we think the axilla would have the most likelihood to have systemic effects? Yes, that is the thinnest skin of the list there. Certainly, if you applied something to the soles of the feet, probably nothing's going to get absorbed from that, right? What other areas would it also likely to be absorbed? Scrotum, certainly. What else? It's like the face certainly would be. Any intertriginous areas certainly would be also likely there. So, all right. Very good. So let's keep moving on then. All right, so which medication would be first line for patients with strep pharyngitis? What do you think? Be daptomycin, amoxicillin, clindamycin, or vancomycin? So this is actually getting into drug selection, what would be most appropriate to use. That was quick. You guys must have had this recently in your medicine course, right? Very good, very good. So the question would be here, though, is like, would any of these medications, other choices, would they also work? Yeah, really, any of them would probably work for strep, but some of them is like kind of using a bazooka to kill a housefly or something, right? So like daptomycin, vancomycin, like way too big a scope. Now, what if the patient could not take amoxicillin? Could clindamycin kind of fit the bill? Yep, absolutely. All right, so that would be a good alternative. If someone had like a true penicillin allergy, couldn't receive that, then you can switch over to use something like clindamycin for sure. Very good. All right. My drysis could be caused by which of the following medications? Would it be fluorescein, trypan blue, cyclopentolate, or carbachol? Start getting into the ophthalmologic medications. All right, very interesting. So, yeah, and again, if you guys have any questions in the meantime, feel free to stop me if we're in like kind of between questions or anything. Just kind of shout it out. So anyway, so fluorescein, what does fluorescein normally use for? Yeah, it actually, yeah, it actually dyes so that way you can use the Woods lamp and actually look for abrasions or ulcers or anything like that. Trypan blue is another dyeing agent they use sometimes in surgery, not really for our purposes. However, so looking at the two other options here, so we have carbachol, which is going to be a muscarinic agonist, and then cyclopentolate, which is, how does that one work? It does, but how does it do that? So again, if you know the mechanism, you'll know kind of what the actual actions of the drug will be. So in this case here, cyclopentolate is it's an anti-muscarinic, right? So by blocking acetylcholine receptors in the eye, it causes that mydriasis to occur. So that's one way to do it. How else could we dilate the eye? So we can either do, say, like an anti-muscarinic, or we could also use something that mimics the sympathetic nervous system. So something like phenylephrine could be used in the eye, and that would also cause mydriasis, right? So that was another option that I could have put on here that would have done the same. Now, carbachol being a muscarinic agonist, that actually causes what? So it lead to, what do you call that? Yeah, so if it's not mydriasis, then it's meiosis, right? Yep, so that would be very good. Perfect. So again, think about the mechanisms and what kind of effects you expect to see, which makes kind of sense though, because if you think about like your rest and digest nervous system with acting on the muscarinic receptors, you probably don't need a lot of light getting into the eyes, which is why they get miotic. Versus if you're activating fight or flight, or if you're blocking the rest and digest system, then that's where you end up seeing that mydriasis occurring there, right? So kind of think about the autonomic nervous system and how a lot of these drugs interact with that. And actually, that's going to be really important when we get into the cardiology stuff coming up in the next couple weeks. Okay. All right. Next, which medication will can result in Reye syndrome when given to a child with viral illness? Would it be Tylenol, aspirin, guaifenesin, or ibuprofen? All right, very good. Yes. So aspirin is always going to be that one. It's like a really classic board style question. So I would certainly know that one not only for now, but also when you take the pants eventually. That's going to be a good question to ask there. Tylenol is not associated with Reye syndrome at all, so that one would be totally fine to use in any children with fever, pain, anything like that. No concern for viral illness in those patients there, right? Okay. Why do you think why would Reye syndrome be kind of difficult to identify in a patient you were giving aspirin to that had a viral illness? Yeah, they kind of yeah exactly. So the beginning signs and symptoms of Reye syndrome looks a lot like an upper respiratory tract infection, fever, malaise, etc. So because of that, they look very similar. That's why they don't catch it till a little bit later on. So that's why education was so important to kind of get those rates down, so that way people knew not to give it. Right. All right. Very good. Which medication would be most likely to cause sedation as a side effect? Be loratadine, fexofenadine, chlorpheniramine, or cetirizine. Very good. Yeah, so what's the difference between the other three options and chlorpheniramine? Yeah, all the other three are second generation agents, and so why don't they cause sedation? Perfect. Yeah, so they have that positive charge on them that prevents them from crossing over the blood-brain barrier. Thus, they should not cause any sedation associated with that, or very little sedation, if anything. But also keep in mind, like they're not really good for like nausea, vomiting, like you would see with something like promethazine or dimenhydrinate, these other first generation. So they don't, the utility is a little more limited, but they also lack that side effect, right? So very good. Let's see. How about a patient with a penicillin allergy? What would they be contraindicated from receiving? Which of the following? Could they get piperacillin, tazobactam, ceftriaxone, aztreonam, or meropenem? So which one would they be contraindicated from receiving? Yes, very good. So the main point with this one is just to show that if you have a reaction to one penicillin, you're probably going to have a reaction to all the penicillins because their side chains look pretty similar. However, what's the rate of cross-reactivity if someone has a true penicillin allergy that they're going to have a reaction with, say, a cephalosporin? Anyone know? Yeah, less than 1%. So it's very safe, especially with something like a third generation, like ceftriaxone. They can totally receive that, or a patient with a penicillin allergy can totally get that with no problems. And most of the time, I have a lot of docs, especially in the ER, that are very hesitant to do so. We normally just do a test dose in the ER, and if they're fine, don't have any issues, and we go ahead and just send them home with something else, or send them home with a cephalosporin. And then also as aztreonam, meropenem, both of those would both be totally safe because again, even though they're all beta-lactam drugs, their side chains are different enough to where it's very unlikely they're going to have a reaction there. Okay. Yes. Mm-hmm. Yeah. So if they cannot receive piperacillin or penicillin at all, then these other three would be totally fine to get. Right. So the question is like, which one are they contraindicated from receiving? And so like when I write test questions, I normally don't write till I don't like to write negative questions saying like, which of the following are true except. I won't write a question like that, but I may write a question and say which one of these would be contraindicated for that patient, or which one of these would be least appropriate, or something like that, based off of history, other concomitant medications, things like that, right? And so I think from the last test, the hematology questions are probably going to be most similar to what you're going to see on this test because now we're outside of kind of the basic fundamental stuff. So you won't see kind of questions about kinetics per se, but you may have questions on why we dose penicillin say 4 times a day, right? And why would that be? Yep, perfect. Yeah, it's a time dependent killer versus say a concentration dependent killer. You may only have to give like say 1 time a day. Good. So the kinetics will come back, but it's usually in regards to how we dose medications or why we give them certain ways. But yeah, those questions are going to be kind of what we run into here. Okay. Which medication could cause iris discoloration? Be pilocarpine, dorzolamide, levobunolol, or tafloprost. All right. So with this one here, so what class of medications does tafloprost fall into? So they treat glaucoma. What classification do they fit into in terms of their mechanism? Good. Yeah. So they're prostaglandins. You can tell because it has prost at the end there. So just like we use latanoprost or bimatoprost, any of those are going to work like a prostaglandin. And so you can see the iris discoloration normally turns what color? Yep, turns brown. And then what else, like what would happen to their eyelashes? Long and luscious lashes, right? So just like we use Latisse for aesthetic purposes, the same thing will happen for your glaucoma patients, right? So it's good to know the mechanism, good to know those kind of unique side effects you're going to see with that. Now, what could happen if I gave a patient levobunolol? What kind of reactions could I see there? So again, going into what class does levobunolol fall into? It's non-selective beta blocker, right? So what side effect could they see? Yeah, so potentially, yeah. So if you had someone with asthma, they could see increased airway resistance, certainly. What else would you see? Say, for instance, with the heart, they get bradycardia, it could worsen heart failure. Yeah. So again, know if you know the class of the drug, you can then link that drug back to a lot of information, right? So kind of categorize those things in mind in terms of what classification they fall into. And so if I know beta blocker, then I know a lot of things about beta blockers. You just got to link it back to those individual drugs, right? Okay. Moving on. Have which of the following would have the fastest onset to treat hypothyroidism? Would it be saturated solution of potassium iodide, Liatrix, liothyronine, or levothyroxine? So the fastest onset of action. Very interesting. Okay, so let's look at why that is. So when we look at our thyroid hormones, what were the two main varieties we had? It's T3 and there's T4, right? It's T3 and T4. Which one's the more active one? T3, right? That one's already active form. T4 has to be converted over into T3 before it has its before it can do its thing. So with liothyronine, that one is basically just T3. So that one would actually have the fastest onset because it basically would be available to work immediately, right? Something like Liatrix was actually a combination of T3 and T4 that would have a little bit slower onset because most of it's going to be T4, kind of mimicking what our body normally produces. And then levothyroxine is what? That's all T4, right? So again, that would have the slowest onset of action. The nice thing with the thyroid gland is that we don't really need very fast changes, right? The thyroid is a very slow gland to respond to changes. You know, you don't test it for weeks at a time when you make changes to things like that. And actually, to give you an example, if I'm working at the poison center and I get a call that says, "Hey, you know, a patient just swallowed a bunch of Synthroid," you know, say a little kid gets into grandma's Synthroid, I actually don't even tell them to look for anything until a week after because that's how long it takes for that T4 to convert over before they really even see any symptoms there. So very slow onset, but that's typically okay because we're not really trying to treat anything super immediate with the thyroid gland. Now, what would this potassium iodide, what could that do for us in terms of hypo or hyperthyroidism? Yeah, so it's kind of interesting because it can kind of do both, right? So if I was giving lower doses of potassium iodide, that can stimulate thyroid hormone production, right? What happens if I use too much of it? It'll shut it down, right? So this is kind of interesting. Depending on the dose they're receiving, they can either get hypothyroidism from it, or they can get hyperthyroidism, depending on the situation there. So it kind of goes both ways. So does that make sense? All right, good. I'll assume you speak for the entire class. So all right, up next, which medication would provide gram-positive and anaerobic coverage for a dog bite? It'd be tobramycin, ampicillin, sulbactam, vancomycin, or clindamycin. All right, so there are two correct answers on here, and again, this is why it's good to know the coverages of the antibiotics, right? So you got to know like what kind of general coverage would you get out of each of the classes of antibiotics. So for instance, vancomycin normally covers what? MRSA, and then more broadly covers gram-positive. Yeah, so gram-positives in general, and then MRSA is one of its kind of specialty coverages there, if you want to talk about it that way. How about tobramycin? What would that cover? So again, these are good things to know. So gram negatives, right? The aminoglycosides cover gram negatives, and will it cover Pseudomonas? Yes, it will, right? Those are also good things to know. Know what covers MRSA, know what covers Pseudomonas, right? Because I'll definitely be asking questions about that, no, for sure. Now, getting into the other two, so clindamycin, again, really good for covering gram positives. You'll also get some anaerobic coverage there as well. How about if I just put ampicillin by itself as an answer here? Would that still work? Why not? Yeah, so you don't really get good anaerobic coverage out of just ampicillin alone. It might cover some of those gram positives that are growing on the skin that you'd be worried about. Because again, when you think about an animal bite, you're thinking about not only the stuff growing in the animal's mouth, but also what's on the skin that could be entering in through the bite. And so ampicillin might get some of that skin stuff, but it wouldn't get any of the anaerobes growing in the dog's mouth. And so that's why we add sulbactam. And what does sulbactam do? So it's going to be a beta lactamase inhibitor, right? And so that's going to help to kind of help to neutralize the beta lactamase that the bacteria is producing, and that helps to give you a lot better anaerobic coverage, right? Does that make sense? So you know why we use that combination there, because it helps to broaden out our coverage quite significantly. Okay. All right. Which of the following can be used to treat both hyper and hypothyroidism? I kind of already gave this one away, so this one should be pretty easy for you. But iodide, methimazole, propylthiouracil, or levothyroxine. Sometimes I'll forget what questions I already asked, and then I'll go ahead and give away answers sometimes. But don't worry, I won't do that for your test. Yes, very good. So yes, iodide would either be able to stimulate thyroid hormone production or inhibit it, depending on the dose you're administering there. Now, PTU and methimazole do what for us? Or they inhibit synthesis of thyroid hormone, right? So they are going to be able to treat hyperthyroidism, and then Synthroid is used to treat hypothyroidism, right? Because that's just replacing the T4 that maybe the thyroid gland is not producing in and of itself, right? Very good. Now, what if I had a patient who had, for instance, say they had thyroid cancer and they had the thyroid gland removed? Which one of these would be useful for treating their hypothyroidism? Synthroid, would iodide do anything for them? Why not? Exactly. They have no thyroid gland to use the iodide to actually produce thyroid hormone, right? So again, kind of think about the clinical implications of a patient's disease state. You know, in this case here, they don't have a thyroid gland. I just replace it completely by giving the T4. Right? Okay. After failing over-the-counter benzoyl peroxide, which medication would next be indicated for facial acne? Be hydrocortisone, adapalene, doxycycline, or lithium? All right, very interesting. So, the main point I want you to look at for this is going to be like kind of where, like what they've already been on before, and then sort of how diffuse the disease is or how severe it is. So, in this case here, if a patient's only used over the counter stuff, well, the first line therapy to bump up from there is going to be what? Topical retinoid, right? So again, this is just on the face, so that's appropriate to use a topical retinoid. So tretinoin would have been fine, adapalene would have been fine, any of those are fine there. Now, why did I put lithium on here? Yeah, that's okay. You can say no idea. It's because lithium can actually cause drug-induced acne, right? So sometimes, medications is good to know what can cause acne because sometimes if I had a bipolar patient who was taking that, then sometimes just getting them off that medication might be enough to fix it, right? So it's important to know when taking away medications would be good too. Now, doxycycline, when would that be appropriate? Yeah, so if it's more diffuse disease, so say if it was covering more of the trunk and the face, certainly oral antibiotics might be appropriate there. Remember, doxycycline only is going to be oral as opposed to, say, like clindamycin or erythromycin had topical gels and things like that available. But oral antibiotics are typically, if maybe they failed topical retinoids and you wanted to use something more systemic, that's where those are going to come into play there. So a couple different options. Okay. And if they failed, say they were on oral antibiotics and they failed that, what could you bump it up to? Yep, so isotretinoin or the systemic retinoids would be appropriate there. All right. Let's say which dosage form would be most occlusive when administered topically? Would it be an ointment, a cream, a gel, or a lotion? All right, very good. So remember, the more sort of oil-based it is, the more occlusive it is, the more it sticks around. It also has that kind of greasy feel to it, right? But the ointments tend to be the most occlusive. What does that do in terms of our absorption of medications? Perfect. Yeah. So the more occlusive it is, the more it's going to increase the absorption there. Certainly, creams, gels, and lotions are going to be less occlusive, so you see less contact time. But they're also more compliant usually because they wash off easier. They don't have to leave that kind of nasty feel behind. So again, just depends on what the patient, what's right for them in that case there, right? All right. How about which of the following medications has good coverage against Pseudomonas aeruginosa? Would it be sulfamethoxazole trimethoprim, amoxicillin, cefepime, or linezolid? All right, so let's look at this one. So, again, this is good things to know. Does something cover gram positives, gram negatives, atypicals, anaerobes, Pseudomonas, MRSA? Those are the kind of things I want you to know in terms of antibiotics. Now, Bactrim, what does that have good coverage against? It does cover MRSA, right? It also it's pretty broad spectrum in general, so that's why you see a lot of UTIs get treated with Bactrim, skin infections, so it's pretty good from that standpoint. How about linezolid? What will that get? That also gets MRSA. Actually, oftentimes we use that for vancomycin resistant Staph aureus, or if you had like a vancomycin resistant enterococcus, that's what we bump up to after vancomycin. It would be Zyvox. Okay. Now, cefepime is what kind of drug? Good. Fourth gen cephalosporin, good. So it's a fourth gen cephalosporin. So remember, your third gens don't really cover Pseudomonas that well. There's like ceftazidime, but that's pretty wimpy in terms of coverage against that. But cefepime certainly we go to for the most part. So like we have a lot of kids who are receiving chemotherapy and they're very neutropenic, they're immunosuppressed. Very frequently, we'll start off with cefepime for them because we want to make sure that we're kind of covering everything, including Pseudomonas. And then depending what they grow back, then we'll maybe scale it down from there. Now, will amoxicillin get MRSA or Pseudomonas? No, it's pretty wimpy in terms of coverage compared to these other bigger guns. So again, these are good things to know for the testing purposes and for clinical purposes, right? That's what we're here for. All right. Alcohol avoidance should occur with patients taking which antibiotic? The acyclovir, linezolid, metronidazole, or cefazolin. And really, if you have an infection, you're probably feeling too bad to drink anyway, but let's figure out which one specifically you should avoid. Very good. This is another classic board style question is like Flagyl and the disulfiram reaction, right? So what happens if you say had a patient who was drinking while taking Flagyl? What kind of reaction would you expect to see there? You vomiting, you get flushing, what else? They're getting sweaty, they're itchy, rashy. I mean, they just look miserable, right? In some of those cases there, that's why we mentioned to avoid it, because it basically can't break down the acetaldehyde, which is that toxic metabolite that builds up after your, that basically prevents the breakdown of that product, the Flagyl does. Keep in mind, acyclovir is probably not a good idea to drink with that one anyway, mainly because alcohol can make you dehydrated, and acyclovir kind of needs to be, you need to keep the kidneys well hydrated in those cases there. But again, we're looking for a strict antibiotic, and so Flagyl is really the one we're looking for there. Okay. Okay. Let's see. Which test should be ordered before starting tazarotene on a 26-year-old female? Be urine drug screen, urine HCG, CBC, or LFTs? All right, very good. So what's a urine HCG? Pregnancy test. What does HCG stand for? Yeah, the human chorionic gonadotropin, right? So you could either get a blood sample or urine sample, but certainly urine is appropriate, for most cases. What would urine drug screen tell us? Yeah, certain drug exposures. Presumably you all passed yours, otherwise you wouldn't be here, right? Or you're very crafty and got around it somehow. Um, uh, Also, you have your CBC, LFCs. Again, not routinely recommended. Now, why do I care about getting a urine HCG along with before I start tazarotene? Teratogenic, because tazarotene is in what classification of drugs? Right, it's a retinoid, right? So because of that, because we know they can be teratogenic, even if it's topical, you still worry about them having some systemic absorption. So I'd certainly check a urine HCG beforehand just to make sure they are not pregnant at the time of starting therapy. Okay, very good. Which of the following would be a potential adverse effect of using prednisone? Would you see hypotension, dehydration, viral infection, or hypoglycemia? All right, very interesting. So we got to look at the adverse effects of steroids. Are like really good to know because so many patients are going to be on these, and it can really exacerbate a lot of different conditions here. So for instance, let's look at the effects here. So looking at hypotension, normally you're going to find that steroids should increase the blood pressure. Does anyone know why that is? So it has to do with fluid balance, right? So one of the things you're going to find is that it holds on to more fluid, which increases the volume of blood in the vessels, which increases pressure. So that's why patients with hypertension usually gets worsened when they're on a steroid like prednisone. Okay. Also, probably doesn't cause dehydration because you are holding on to more fluid, so that's not really the case there. And then in terms of blood sugar, what does it do for you? Definitely increases, right? Remember, these are glucocorticoids, and they're a stress hormone. And when you're stressed out and you have say, a bear's running at you, you typically want your blood sugar to be high or low. High, because you want to provide, blood sugar to all those muscles. And, think about you guys. You're all probably chronically stressed right now. You probably have a lot of cortisol floating around. So your blood sugar needs to be higher because your brain needs to work in order to pass your test, right? Presumably speaking. But so hyperglycemia is typically going to be a side effect from using a corticosteroid like a prednisone, right? Dexamethasone would do the same thing. Now, why would viral infection be a potential adverse effect? Yes, it is immunosuppressant, right? So it suppresses your ability to fight infection, which is why typically you're going to find that bacterial illness, viral illness, all can be a risk, especially the longer you're on it. Now, a 5-day course of prednisone probably not going to increase your chances that much, but if you're on it for a longer term, certainly that could be a big risk there. So that's something we definitely watch out for. Okay, does that make sense? All right. Moving on. Which of the following has coverage against MRSA? Let's hope that I didn't give this one away. It would be gentamicin, clindamycin, cephalexin, or polymyxin B. Very good. Yes, clindamycin definitely covers MRSA. It's a very common drug we use for skin infections, abscesses, all that good stuff. Remember, it also has good anaerobic coverage, which is why we liked it for like the dog bite that we mentioned before. Gentamicin will cover what? Pseudomonas, and then more broadly, what would it cover? A lot of gram negatives, right? So gram negatives, Pseudomonas, that's where you're going to see most of the coverage there. Now, Keflex, what would that cover? So this one is pretty broad spectrum. It does get a lot of like MSSA, right? So think about Keflex being, it's what generation cephalosporin is it? First generation, right? So it kind of gets, some gram negatives, some gram positives, does cover MSSA. So again, it has fairly decent coverage, which is why you do use it for a lot of different things like UTIs. You can use it for minor skin infections. There's a lot of different use cases for it, right? But yeah, so those would be clindamycin would be the only one that covers MRSA there. Polymyxin B is actually one we use more topically most of the time. Really broad coverage against a lot of gram negatives as well. And actually, we've used it occasionally IV to treat things like Pseudomonas, but it's pretty rare because it's very, very toxic when you use it systemically. But that would also cover Pseudomonas. Okay. When dealing with time-dependent antibiotics, which of the following is true? Post-antibiotic effect occurs when levels are above MIC. Peak levels should be measured to assess efficacy. These drugs often require frequent dosing, or dosing decisions can be made from levels after one dose. Yes, very good. So we kind of talked about this a little bit earlier, but certainly they do require frequent dosing. So in those cases there, if I was measuring levels, would I want to look at peaks or troughs? Why troughs? Yes, you want to make sure it's above the MIC, right? So if I'm doing like vancomycin troughs, I want to make sure that it's in the right range to make sure I'm above the MIC for that bacteria, right? When do post-antibiotic effects occur with concentration-dependent killers? It's not above, that's usually when it's below, right? So concentration-dependent drugs like a fluoroquinolone, you get that post-antibiotic effect and you drop below the MIC, it still ends up killing off the bacteria, which is why you can dose them just one time a day, right? Now, the green answer here, dosing decisions can be made after one dose. Why is that false? Yeah, you have to wait till you get to steady state, right? So depending on the drug, you may have to wait till 3 or 4 doses in order to hit to that 4 or 5 half-lives, right? So for instance, vancomycin, we don't check a level until before the third or fourth dose, and that's long enough so that way we can go ahead and make sure they're at steady state. Because if I check it too early, what am I likely to do? Yeah, it's going to look too low, and then I'm going to say, well, I need to give my patient a bigger dose, or I need to give it more frequently, and then when I get a true level back, then it's going to come back too high, and then I got to start chasing my, it's almost like chasing your own tail around. I'm trying to get the levels right. So always wait till you get to steady state before you check a level. Okay. All right. So which of the following medications can prolong the QTC interval? It's going to be Bactrim, clarithromycin, ampicillin, or clindamycin. Almost an even split here. So just like when I mentioned things that like inhibit CYP3A4, that's always like a big buzz thing that you should probably know about. Anything that prolongs QTC, you should probably also know, right? Because that's a big interaction that oftentimes goes missed. And what is the outcome if I have a patient with a prolonged QT? What could happen? Torsades, yeah, they can develop torsades, and that is a life-threatening arrhythmia, right? So because of that, we want to be really cognizant of that. Make sure we're not giving too many medications to prolong QTC. Make sure we're not putting them at undue risk for that. So remember, your macrolides prolong QTC, okay? So be really careful with that because when we get into cardiology and we start to talk about different medications and how they can affect QTC, by themselves it may not be so bad, but adding on multiple drugs that do it can become the problem, right? And again, how do they prolong the QTC? What did I talk about there? Good, so they're prolonging the ventricular repolarization. Anyone remember the mechanism there? Yes, blocking potassium efflux, right? So it's extending the time it takes for the ventricles to repolarize. So it kind of messes up the refractory periods there, and that's why it kind of predisposes you to develop that arrhythmia, torsades. Does anyone know the treatment for torsades? Yeah, IV magnesium sulfate. That's definitely going to be that's another good board style question, or you'll cover that in ACLS when you get there. Good. So that's definitely a good thing to know. All right. Which medication is most likely to cause tinnitus as an adverse effect? It would be ibuprofen, acetaminophen, aspirin, or Zelestine. Very good. Yes, aspirin. That's a known thing. In fact, it's not just with like super therapeutic doses. This can happen at normal therapeutic doses, and some patients are just more predisposed to it. But certainly, I remember I had one call at the Poison Center where a young lady had tried to commit suicide by taking a bunch of aspirin, and so she was, starting to regret the decision. Called 911, and it was interesting trying to talk to her because I was just like, "Well, how much did you take?" And she goes, "What?" I go, "How much did you take?" "What?" She couldn't hear me because the ringing in her ears was so bad. And so eventually I just said, forget it. Obviously, it's too much aspirin. Send the 911 out there to go pick her up. But so it's just one of those things where it's just like, oh, actually, you can see the drug effects in real time there because, it's a very unique sort of side effect with that medication. Good. All right. Last question here. Which medication should be used to treat acute otitis media in patients with a legitimate penicillin allergy? Should I use linezolid, ceftonir, levofloxacin, or benzathine penicillin G? All right, very good. So this question comes up too because you're like, well, a lot of people say, well, you could treat it with levofloxacin, but it's one of those things where, again, what kind of patients are frequently getting acute otitis media? Kids, right? And what do we say about Levaquin? Probably avoid it in kids. So while theoretically you could probably treat it, we're also still seeing a lot of issues with like resistant strep pneumo and things like that, making your fluoroquinolones kind of less effective overall. So I would probably say ceftonir would be a good option. Now, ceftonir is what kind of drug? Third generation cephalosporin, right? So we said it had a low cross reactivity. So even if they have a true allergy to penicillin, I'd feel totally comfortable giving them ceftonir, especially if you give them a test dose in the ER or in the urgent care. They'd be totally fine with that. Linezolid again probably would not be a good option there because again you don't really get any like coverage for gram negatives like H flu and things like that. And then benzathine penicillin G wouldn't be broad enough either. Now, which one of these has to be given via the intramuscular route? Yeah, I remember that one comes in that oil mixture, and if you do that IV, then you can cause an embolus potentially. But that's a good alternative for like patients with strep throat because they can just do a one-time dose and they're kind of done from that standpoint. But that would also cause a cross-reactivity with the penicillin allergy. Okay, does that make sense? That one's a little bit tricky. So frequently, the question is going to be which one is best used or which one is the best option. So kind of keep that in mind. Just because Levaquin could potentially work, because it's usually going to be a kid, and because of resistance issues, that's why we typically go with the third gen cephalosporin. Okay. All right. So the winner is A Bug's Life. They overtook Frodo. Frodo had his reign taken down. That's okay. So that's it for the Kahoot. Do you guys have any questions that I can answer for you? Is that helpful? Good. Good. Yeah, no problem. Um, oh, that's right. I guess those don't automatically post. Yeah, I'll make sure you guys get those. Do you see feedback after you take it? Okay, I'll see if I can set that up to where you can see that. If not, I'll give you guys the answers so that way you can see what you got wrong or right. That should be the goal is you should definitely know the mechanisms of actions of drugs. Yes, for sure. So like common interactions, side effects, like unique side effects, because which one causes nausea, vomiting, diarrhea. Like, well, any drug can do that. But things like tendonitis, that's pretty unique, right? Or things like QT prolongation, pretty unique. That's good stuff to know, right? And thank you for the Starbucks gift card. I got a nitro cold brew and it was delicious, so I really appreciate that. Yes, lovely. Any other questions I can answer for you? I'm sorry? Yeah, I'm gonna post a Kahoot. I'll have the video up too. This should have recorded, I think, and so I'll be able to post that up so you can go back through and review and see if I said something you forgot. Then you can check that out too. Okay. All right. Please send me emails if you have questions. I want to hear about them so I can set you straight before the next test. Right. So I want to make sure you guys feel very comfortable heading into that because this is gonna be a tougher one than the first one. Okay. I want to set expectations appropriately. All right. Have a good day. Bye.